Welcome, everyone. It's the top of the hour. We'll get started. I'm Dia Waguespack in Houston. I'd like to welcome you to today's GlomCon. Today is part of our Clinical Trials Conference Series, which is a joint venture between GlomCon and NephCure, and our title is Targeting the Podocyte as a Treatment Approach for FSGS.
First of all, I'd like to thank GlomCon and NephCure for the opportunity to share this program that we've been working on at Pfizer. And some of the topics that I'll cover today is just a brief background on FSGS, and also share why and how we selected the program that we have to move forward in development for FSGS, and take the opportunity to share some preliminary data that we have from our ongoing phase 2 trial. So with that, I'll start with just some basic background in FSGS. And as you all are well familiar with, it's a rare and progressive kidney disease that can affect renal filtration and may lead to end-stage kidney disease. In the US, the prevalence is estimated to be about 40,000, though these numbers are estimates. I don't think they're very good counts, at least, that have been reported in the literature. What we do know is that at least amongst adults with nephrotic syndrome, that FSGS accounts for about 40% of those cases. With FSGS, there's a disproportionate impact on Black patients, where we see Blacks 4 times as likely to have FSGS as whites with nephrotic range proteinuria, and in turn have a 4-fold greater risk of end-stage kidney disease due to FSGS when we look at Blacks relative to whites or Asians. The disease presentation can vary, though I think proteinuria is pretty much a central finding for all these patients, though to different degrees. And we know that for some patients, they present with very acute onset of proteinuria versus others being a very gradual or insidious onset. But at the time of presentation, nephrotic range proteinuria is quite common, affecting about 2/3 to 3/4 of patients. And patients often have some degree of microscopic hematuria, affecting about 1/3 to half of patients. And hypertension is quite common in 40 to 65% of patients, and that some patients, up to half of patients, may actually present with renal insufficiency at that initial presentation. And so from a clinical standpoint, we do try to classify the disease, primarily thinking about it in terms of being primary FSGS or idiopathic, or having a secondary cause. And it's somewhat important to distinguish that in terms of thinking about the potential treatment options. And so probably universally for the patients who have proteinuria, one would consider treating with ACEs and ARBs. And in primary FSGS, really consider the appropriate use, whether it's appropriate for patients to use immunosuppressive therapies that includes corticosteroids or other immunosuppressants. And while these treatments are effective, there are some high rates of treatment failure or relapses. And a particular unmet need today is the fact that a significant proportion of patients, despite available therapies today, do progress to end-stage kidney disease. And in particular, those who have nephrotic range proteinuria, more than half, so about 50 to 60%, progress to end-stage kidney disease within about 5 to 10 years. And for those who do go on to have a transplant, unfortunately, there's a recurrence rate of about 30 to 40% post-transplant. So as you all know, there have been histologic classification system, probably well known as the Columbia classification system, that looks at classifying based on findings primarily under light microscopy, where one has these various categorizations that are listed here on the left side of the slide. But despite those histologic variants, by light microscopy, what's really a common finding is ultrastructural findings. So those on EM, where we see podocyte alterations. And the typical finding would be